Hello. This lecture about EUS from Diagnostic to Therapeutic was given at the Vietnamese Gastrointestinal Endoscopy Congress held this year in March. My name is Janine van Hoofd and I'm a gastroenterologist at the Leiden University Medical Center. I do have some disclosures. The learning objectives of today are review current roles of EUS in gastrointestinal practice, emphasize diagnostic applications, discuss emerging therapeutic EUS techniques, and explore the role of EUS in liver disease. Why EUS matters? EUS combines endoscopic and high-resolution ultrasound. It provides detailed visualization of the gastrointestinal wall layers and adjacent organs, and it enables precise tissue acquisition. The main diagnostic indications. An important indication is subepithelial lesions, particularly in the stomach and in the esophagus, and staging of cancers also in the stomach and in the esophagus. Furthermore, it's very feasible for the assessment of biliary obstruction, evaluation of pancreatic masses, and evaluation of unexplained abdominal pain. Here you can appreciate the radial endoechoscope. As you can see, you can look at subepithelial lesions with the endoscopic view, and here you see it with the radial EUS view. And the same is applicable over here. You can also use it to interrogate if there are stones in the biliary tract, as you can see here, or if you want to look at the depth of the invasion of a tumor. So you can use it for accurate staging of esophageal and gastric cancer, assessment of tumor invasion depth, evaluation of regional lymph nodes, and it can guide treatment decision. Here you can appreciate the linear EUS scope, which has a different way of viewing at the tissue. You can appreciate it here in the video. We are interrogating a pancreas and searching for a lesion in the pancreas. You can see the kidney below, and here you can see a small lesion in the pancreas. So here you look with the linear EUS scope. So you can particularly use the linear EUS scope for pancreatic and biliary diseases, for detection of small pancreatic tumors, for characterization of pancreatic cysts, for evaluation of chronic pancreatitis, detection of common bile duct stones, and it can be complementary to CT, MRI, and ERCP. Here you can appreciate if you use advanced diagnostics like elastography in the upper quadrant, which is telling you how stiff the tissue is. And so if it's blue, it's stiffer and it's more likely that it's a malignancy. Then you can use also contrast enhance. For that you give micro bubbles, for example SonoView, and that will show you where the vascularization is and if a lesion is, for example, highly vascularized. And nowadays we have this integrated in the EUS scope, and then it's called DFI, and it's also telling you if a lesion is vascularized or not. In this video I'm going to show you how you can do your tissue acquisition and besides that continue with an ERCP. This video is made by my colleague. it revealed that you can do EUS tissue acquisition and drainage in the same procedure. And if you do this tissue acquisition, you can either use an FNA needle or an FNB needle. And puncturing a pancreatic lesion, it's highly sensitive to diagnose pancreatic carcinoma. It enables molecular and histological analysis, and it has a low complication rate. Which needle to use is clearly depicted in this consensus statement published in 2024. And it's actually stating if you get tissue from a pancreatic lesion, you should rather use an FNB needle over an FNA needle. And whether you use a fork tip or a Francine needle, as long as it's an FNB needle, it is fine. And then we have EUS in liver disease. I think nowadays that's more and more often used. You can do EUS-guided liver biopsies, you can detect small hepatic lesions, you can evaluate the portal hypertension and the potential role in the RFA for hepatocellular carcinomas. And here you can appreciate how that's actually done. Here you see how the portal pressure is measured. So you puncture an upper vessel and you puncture a lower vessel, and with that you can calculate the difference in the pressure and you have an idea about the portal pressure. And here you can see if you want to puncture a lesion with an EUS scope. You can also do other techniques, for example EUS guided drainage of fluid collections. You can do EUS guided gallbladder or biliary drainage, EUS guided anastomosis creation, EUS guided pancreatic duct drainage, EUS guided RFA. You can appreciate the needle over here, and you can also use it for celiac plexus neurolysis in case of significant pain. So I will first of all highlight the EUS guided drainage of the fluid collection. Another video also made by the same colleague. First of all, I think it's always important if you're going to do an EUS intervention that you have a look at the images made already. And here, though it's in Dutch, I think you can understand the stomach and the necrotic collections are depicted. Here you can appreciate the collection with the EUS, and you can see that there are solid components in the collection. Now you have to look over here. You can see we burn a hot axius into the lesion, and we are going to deploy it slowly. This is the distal flange. You pull it back against the gastric wall, whereafter you deploy the second flange within your EUS scope. And then you switch to the EUS, to this endoscopic image, and then you see the result of the intervention you have just done. Another option we have nowadays is also to do EUS guided gallbladder or biliary drainage. And I think by now there are quite some guidelines out when should you do what. And in most of the guidelines it is still stated that first you should try an ESCP, and if that one is failing you can continue to EUS guided drainage. Also therefore we have a video, and you will appreciate how my colleague did an EUS guided drainage from the stomach to the biliary tract. Though you see him speaking, you don't hear him speaking. So I will tell you, we have the papilla on a diverticulum, and then we decide to go for the antegrade stenting. You can see he's looking for an appropriate spot. First looking at the lesion again, here you can see the tumor that's blocking. And then going to locate the left liver lobe and see if there is a duct that's dilated enough to puncture it EUS guided. But you want to have a bit of parenchyma in between. And then you insert a 19 gauge needle, puncture the biliary tract, and under fluoroscopy you can appreciate that he went into the biliary tract, made a cholangiogram, and is then trying to advance the wire. And sometimes it's difficult to advance the wire, so you need a bit more stiffness, and for that you can use your 6 French cystotome, which is inserted over here. And then you can see that we're nearly there, that we nearly got the wire all the way down to the duodenum, as you can appreciate over here. And you see the wire going deep down in the duodenum. So at that moment you are in business. What else? You can do also EUS guided anastomosis creation. This time it's with music again. This is my place where I work. And this is an extensive
It would be like summer rain.
editorial video.
It could wash the pain away. As long as I'm with you, as long as I'm next to you. Will it be too much to stay? All I know is we're the same. okay, but I will meet you half the way. As long as I'm with you, always right next to you. Happening often, running like water, turning to nothing. Used to be weak and now I'm not leaving, I won't repeat it. Never forgot, I landed in soft, I promise I got you. Oh, I got you. It can be better now. I can be better now.
And then, of course, I also want to highlight a bit the challenges in Vietnam. I think there are limited availability of the EUS equipment as it's quite expensive. There's also a need for specialized training. There's a cost of the procedures and especially the accessories, and need for multidisciplinary collaboration. The need to get specialized training There has been research done. It takes quite a bit of time to get yourself up to bar to do this kind of procedures. So this is a prospective registry done by one operator, checking the procedure time and looking at the technical success, the clinical success and the adverse events. And what you can see then, that were 72 patients done over a time period of 6 years, with a mean procedure time of nearly an hour, and 32 procedures were needed to achieve a technical success of 69% and a clinical success of 86% and an adverse event rate of 10%. So with 12 cases per year, that will take you 2.5 years. So I think you should make a combination if you do the training, if you embark on it. You can use ebooks, you can do an observation, you can work on simulators or hands-on, and you might need an apprenticeship training. And I think it's important that you make your own individual training plan and find a proctor. There's also a curriculum from the ESGE in Europe published in 2021, which you can use as a background. This is an example of a training where you can go to. And then what about the future directions? I would say the EUS training programs will expand and are dearly needed. There will be an increased use of EUS-guided biopsies taken. There will be a development of therapeutic EUS expertise and integration with oncology and hepatology service. The learning objectives, as stated before, are to review current roles of the EUS in gastrointestinal practice, to emphasize the diagnostic applications, to discuss emerging therapeutic EUS techniques, and explore the role of EUS in liver disease. Keep moving forward.